Administrator for Region 4, and she's going to speak to us on the importance of communities embracing trauma-informed care as prevention.
Good morning. After so many welcomes, my mind always goes back. I don't know how many of you can relate to this. I was raised in the South, and at Easter time, you'd have to learn this speech. And you'd have to go before the whole church and give this speech. Well, when we were young, you had to do all these welcome speeches. And I got so sick and tired of welcome speeches. So I kind of flash back now as a grown-up. When I follow and come into all the welcomes, I want to do my little split and all of that, my curtsy. But I probably have to have someone help pick me up off the floor. So I won't do that this morning. It is indeed a pleasure to be here this morning. For those of you in the room, I know a lot of you receive funding from SAMHSA. We're the Substance Abuse and Mental Health Services Administration. We're one of 11 Department of Health and Human Services agencies up in DC and Rockville. As you know, SAMHSA and other federal operating divisions have been charged right now. We're in the throes of the opioid crisis right now. So we're giving the opioid crisis a lot of attention right now. But we know we have other issues at hand. And trauma response and being trauma informed, however you want to put it, is at the top of that list, and it's very important. I am a preventionist at heart. I spent almost 11 years as the Director of Preventions for the Department of Mental Health in Montgomery, Alabama. My husband is a 30-year veteran of the Armed Services. I'm the mother of a veteran, I'm a sister of a veteran, and I know how important it is for us to address trauma, not only in children, but in adults. And I don't want to belong the subject a long time, but I just want to tell you my own personal experience. I lived in Hawaii for 3 years, and I was on faculty at the University of Hawaii in the Department of Psychiatry. And in the evening time, I worked in the men's and the women's prison. And it was probably one of the greatest experiences of my life, professional experience, because I came to the conclusion that, believe it or not, we have a lot of talented people who are sitting up in our prison systems. And in the women's prison system, I would talk to young women who are in the prison system. And in Honolulu, you have, when you look at the big picture of prostitution, you have 2 areas of prostitution in Hawaii. And that's either on the track, as they call it, and that's in Waikiki or in Chinatown. And the young ladies from the track and Chinatown who were in prison, after we had our session, I used to work for Parents Anonymous in the evening, we'd have our session, sit around and talk for maybe 30 minutes or 45 minutes. And I mean, talent like you've never seen before. Could draw, could sing, could play instruments, could sculpt. I mean, talent like I have never seen. And the women would always talk about their childhood and how they were raised and how they ended up either in Chinatown or the track. And I remember this one young woman who would always just, do these beautiful black and white, these pencils for me, these pictures, and I'd take them into work and give them out. We'd frame them and put them all around the wall. And she would say, you know, Stephanie, you're the first person to ever listen to me about my experience. You know, I didn't wake up one day and want to be on the track. At 8, 9, and 10 years old, as far as the abuse that she had to endure as a child. Left home at the age of 11. 11. And she had been on the track for about 7 or 8 years. When I met her, she was 18, 19 years old. We have to look at how we can prevent trauma. I know we have to treat it. I know all of us in this room want to be trauma informed. We want to be trauma responsive, but we've got to look at some better ways in our society to prevent trauma from occurring. I heard some wonderful examples around the table last night when I got in at dinner. and I'm sure you're going to enjoy a lot of the segments that you have today. One of the things that Joan and I were talking about last night is that, a lot of times our interventions and our treatments don't work because people haven't healed. And for some reason, we think that we're so smart and we have such expertise on the clinical side of the house that we're going to just automatically make people heal through time and through clinical experiences. And I think sometimes we have to stop and really give people time to heal and heal in their own way. But one of the things today, this is National Recovery Month, September, that celebrated all over our nation. And keep that in mind when we listen to the sessions today. And Joan is a force to be reckoned with, so when she comes up, we're gonna have to clear the stage and move these tables back. But the Office of Behavioral Health Equity, OPE, as we refer to it at SAMHSA, has some wonderful resources, and I don't want to sit down and tell you, please go to SAMHSA's website if you haven't already, to OPE. If you just Google's a wonderful thing, isn't it? Anything you ever want to know, you just Google, If you just go to Google and put in OBHE, the Office of Behavioral Health Equity, Dr. Locke Wong at SAMHSA has headed up that office for over 9 years. We have some really, really underutilized between the SAMHSA store and OPE. You could find all the resources you want on trauma-informed and trauma responsiveness that you could possibly need, but we have to look at how we can prevent in our communities trauma. And here in Johnson City is I think one of the most excellent, and I'm gonna take the chief up on his pitch to talk to other policemen in my region as far as bringing this on in their region. But we wanna look at it to prevent it, because we're spending a lot of time and money as far as in treatment. But we want to look at how we can better prevent trauma in the lives of children, teens, and adults, and families. Because if we look at our communities across the nation right now, a lot of our communities are broken, and they're broken because of trauma. So with that being said, I think it's uplifting. I'm not going to get in the doldrums, but I think we have a lot to share between the folks who are here, the audience, and the states that are represented here today. Please, I'm going to have to be leaving out before lunch, but if there's anything that I can answer for you, all of you in the room, if you're not in this particular region, you have a regional administrator in your region. I'd be more than happy to give you their contact information, and I would strongly recommend for you to get in contact with them to see how you can partner with SAMHSA in your respective region. Thank you.
Thank you. It's my pleasure now to introduce for the first session Dr. Joan Gillece, and she comes here in a minute. When I came to the police department in 2012, I had worked many years at East Tennessee State University before, and that's how I met Dr. Clements. You probably don't ever want to make your way into my phone. That's just a little hint there. But when I was at the police department doing a crime prevention grant, one of the programs that we started that I'll mention a little bit later was a program to reduce recidivism. So the program manager and I went to Florida to a probation and drug recovery program, a conference, national task, and there I met Dr. Joan Gillece, and she was talking about this topic. And because as a community crime prevention coordinator, what I do is work a lot more with the community on the causal factors of crime, as well as with law enforcement. But I really felt like I was hearing what to me was paramount to the cure for cancer, and I had to come back and tell my town. So at the end of that Joan's session, I gave her my card, introduced myself, and I told her, and sometimes I'm bad to put my foot in my mouth, and I said, we're making this up at home. We've got to educate our town. I need a bigger fish. And she said, well, I'm a pretty big fish. And so with that this morning, I want to welcome Dr. Joan Gillece, the director of the National Center of Trauma-Informed Care.
It's great to be here, but I really don't think I call myself a big fish. At least I hope I didn't. So it's really great to be in Johnson City. I came here for the first time, I guess, Becky, what was it, like 5-6 years ago? And what a great town. It's hard to get here, I have to tell you. You know, I would have had to fly, I live in Annapolis, Maryland. I would have had to go to Baltimore to get on a plane, to fly to Atlanta, to then take another plane, to come to Tri-Cities. So I drove. And it was so gorgeous. I just enjoyed every minute of it. It was just a lovely, lovely trip. And the first time I came, Becky, I don't know if you remember, I thought, okay, I'm going to Tennessee. I flew into Nashville. And I said, I went to get my rental car, and I said, I'm going to Johnson City. They said, well, you're going to be driving for 4 hours, or whatever it was. Remember that? So then to get home, I was going to have to drive back to Nashville, which would have taken me backwards. So I drove that one too. So now I've learned, when I come to Johnson City, I'm driving. So it's really great to be here. And the work that has happened through Becky and through Andrea's work, through both the university and the collaboration with community and police department, is clearly a model. It is clearly a model with the multiple systems that you have engaged, and it's really evident here. I'm really wondering who all's in the audience, so I'm just gonna call out some agencies, and just so I can see who's who. Education. Okay, good. Police. Great. Legislators. Social work. Okay. Mental health. Okay, great. Substance use. Social services. Who am I missing? Spiritual care. That's great. That's great. Homeless services. Wonderful. That's what I said. Children's hospital, child welfare. That's great. Administrators. Workforce development. Great, great. Recreation and parks. Okay. How about people receiving, or peers, consumers? Okay. So that's one thing that I think as we move forward, it's so important. Last night after our dinner, I went upstairs and I was watching the returns of Boston, right? And what an upset that you had Ayanna Pressley win the seat for the Democratic seat for Congress, and there's not a Republican challenger, so she'll be the first African-American woman representing Massachusetts in Congress, hopefully. But I love what she said. She said, those closest to the pain need to be closest to the power, right? So I urge you, as you move forward, include the voice of people that you're serving, okay? Because that's where the power comes from. And I think what she means by this, it's not just that we're saying everybody in pain has to be in the power, although she's a trauma survivor. She's a person who grew up in huge poverty. She has this passion, you know, for this work, but it's just around the table. As Stephanie said, SAMHSA, the opiate epidemic is huge, as it absolutely should be. And so we, with the National Center for Trauma-Informed Care, have been doing quite a bit to address the opiate epidemic with different communities. So Dayton, Ohio, huge problem. You know, you have certain pockets of places, but Dayton is really, really struggling. And I don't know which way the highways converge or whatever it is, Dayton, Ohio is really having a hard time. So the judges called and said, can you come and do a training in trauma-informed care? I said, no, that's really not what you need. That you really don't need me to come and do a training on trauma-informed care. Everybody's already traumatized. You get what? Let's do an experiment. I said, why don't we bring together a whole group of people that have different perspectives on the epidemic. Let's bring together families, let's bring together the police, let's bring together legislators, let's bring together providers, right? Let's bring together the judges. But I said, most importantly, let's bring together people who are struggling with addiction currently. And they're like, really? I said, yeah, let's try this. So the judges sent out letters. You know, when judges send letters, you show up, right? So the judges sent out the letters. We held a forum in the courthouse. There were people coming in orange jumpsuits that are coming right from the detention centers. And we, excuse me, had an all-day forum on looking at the epidemic from different perspectives. It was incredible to see the chief of police sitting next to someone they used to arrest all the time, to see the family members sitting with providers, to see the legislators saying, we had no clue. At the end of the day, excuse me, they all agreed upon one thing that they could do different. And this is everybody coming together. We had the governor's office there too. Somebody said to me from this meeting, you know what, no one was on their cell phone all day and no one left. I said, it was that incredible watching this interaction. And at the end of the day, we decided what one thing we could do that would make a difference. And you know what it was? It was when you receive Narcan, when you're revived, it's a perfect place for support, for an intervention, for healing to begin, but instead you receive the Narcan, you're revived, and you keep going. Right? Everyone agreed. The police said, we would love that. The family said, we would love that. The people in addiction said, we would love that. Everyone said. So then the judge said, okay, we're redoing contracts. We're working to redo contracts. So providers now need to be responsive immediately, and we started looking at peer support. To be able to have people who have struggled with addiction being out there supporting, they can have Narcan with them, right? And to be able to immediately bring that person into some kind of support services. Because really, on a deep level, it made the people struggling feel like they weren't worthy in a very, in a strange way, right? Most of the folks there had been revived 2 and 3 times, and they couldn't get into treatment. They could not get into treatment. So bringing the voice of people that you are serving is really so critically important if we're going to come into this together. So next time, Becky, when you do your next forum, we can have all these people receiving services that can advise us. I love that Stephanie talked about living in Hawaii. One of my favorite people was the warden of the women's prison. His name was Mark Patterson. He had been an officer. He had been in the men's prison. He was asked to take over the women's prison, and what I always hear from everyone, give me 25 men to 3 women, men are so much easier. Well, he thought that, but he got in there and he said, you know what? Every woman is here because of something that happened to them, right? Whether you have domestic violence, whether prostitution, whether all substance use, but it all boils down to something in their past that was extremely painful and they were self-medicating on. So he said, I'm going to change this up. So what he did was the first thing that women were told when they entered into his prison was, you know what, nothing I can do about your time, you have to do it. But while you're here, we want to help you heal, and here's the big thing, we forgive you. Forgiveness is a big deal when we serve people, particularly, again, if you're looking at the opiate epidemic. And so many people I've worked with, friends of mine whose kids have been addicted, that forgiveness is really huge because the things that we do in order to support our habits, sometimes we're not really proud of, right? So how can we start that healing? And that healing starts with forgiveness. It starts with forgiving ourselves. I've had so many women say to me, the things I had to do in order to support my habit were so re-traumatizing me that all I did was use more. Right? So healing, forgiveness, and these are just important messages as we think about our treatment programs, right? As we think about maybe we switch from that behavioral control to comfort. Maybe we go from into collaboration and a partnership with the person served. So I've been doing this work for a long time, and I'm a trauma survivor too, and I'm a person who has grown up in difficult situations and started volunteering in the state hospitals when I was like 14 years old, maybe to understand my mother's mental illness after my father had died suddenly, leaving her with 4 kids, and we were very poor. And so I started volunteering in the hospitals then. And I thought, you know what, there's something about the folks that are in here, I think I knew this very, very early on, that is really about hurt. And so I kept going. And then I trained in forensics. I was at Maryland's maximum security facility for 15 years, and then became assistant director for Maryland's mental hygiene administration, the state mental health organization. And there I had special needs population. So I had everyone that didn't receive their mental health services in a traditional setting. So I had people in jails, I had homeless, I had people with substance use, I had the deaf, I had people living with HIV, I mean, you name it, I had everybody that wasn't in traditional mental health care. And through a few grants that I had from SAMHSA back then, I was able to really look at a little bit about what was behind all of these folks that ended up in all these different systems. And what was so evident to me, and this was 20, 25 years ago, was that impact of trauma. So whether you're in an orange jumpsuit one day, you might be in a homeless shelter the next day, you may be trying to get substance use services the next day, you might be trying to get mental health services the next day. So we were all treating the same thing differently, right? Because none of us were looking at the cause, we were just looking at that behavior, right? And we all stayed in those lanes. John Breer, psychologist in California, says, if we appropriately treated childhood trauma, the DSM would turn into a pamphlet. Everybody know the DSM, it's like our Bible with every diagnosis imaginable, but the DSM, excuse me, would turn into a pamphlet. Because what we often do is we pathologize an understandable response to an unfortunate situation, right? That's why I love Handle with Care. You're gonna hear about that this afternoon. And Handle with Care is such a prevention. So it's really starting to prevent the child from going down that next, that next issue, that next stage of being diagnosed ADHD, oppositional defiant, whatever, when the behaviors are directly related to what that child experiences. Now, next we have to go into how to prevent that from happening in the first place, but that's the goal. So what I learned then was, without looking, and really I just stumbled upon it all those years ago, was I had a grant from SAMHSA to look at violence in women, and I was doing a program in 3 detention centers in Maryland, really looking at parity for women's services versus men's services in criminal justice. And just by chance in our evaluation, we asked about trauma histories, not even looking for it. And there we found 85% of these women reported huge histories of trauma. Same thing within substance use. So we really looked across systems at the trauma and found that there was an overwhelming overlap in the numbers of folks that really were suffering from incredible pain. And it's what we do to protect ourselves from feeling it again, right? It's what we do to protect ourselves from that pain. And so that changed my life's work. It changed to looking at, again, not just what is wrong with you, but what happened to you, but more importantly, now I'm totally focused on, you know what, it's not even what happened to you, it's what's right with you. What's right with you. And you start from that strength-based approach. Most of the people that we serve have been pretty broken. Most of the people are in huge pain. And if we can just start our services, and a lot of this stuff, I'm going to just tell you all sorts of examples that I've learned from other places that have moved into this approach. I'm not going to tell you what to say, what to do. I'm not going to give you a lot of data, a lot of statistics. I'm going to tell you real life examples of what I have seen work that has elevated both the person served and the workforce. It elevates your workforce because your workforce doesn't want to just be rule enforcers and level giver-outers and behavior. They want to help people heal, right? So looking at not just what's wrong, but thinking about what's right. So think about all the different systems that you work with. Think about if somebody comes into a mental health system or, for example, comes into a residential facility, and the first thing that they're asked is, what drugs are you on? How many times have you been arrested? Are you seeing your probation officer? On and on and on. If you just held up and just started by saying, welcome, we're so glad you're here. Tell us what you do that you're really proud of. Well, you know what happens? People are like, really? No one has ever asked me that. We did it at a children's program, residential program in Virginia, in Stanton, Virginia actually. And the kids come from all over the state. And oftentimes, if their parents aren't able to transport them, they come in a sheriff's car, handcuffed to a car seat. That's really true. They come handcuffed to a car seat with the sheriff driving them. So they come in to the facility, oftentimes with their Glad trash bag filled with all of their belongings. Normally what happens, they come in, the staff meet them. Now this is a child, right? These are kids. Comes in with all their belongings in a trash bag. if they came from juvenile services, foster care, right? The staff puts on their gloves, right, and goes through the bags and checks what you have. You've also, I see a lot of head shaking, checks what you have, takes them away, puts them in a locker, and says, we can give you these when you go back. Imagine how you feel. Your teddy bear that you might have can't have that infection control, can't have the picture of the family, all of these different things, the can'ts. So of course that child is orienting into the system a little bit dysregulated, right? We switched it up. First thing that child is asked when they walk in the door is, tell us what you value. Well, the clinical director at first was like, do you really, come on, what you value? We need to get this paperwork done. Well, just hold up a minute, you're gonna get much better results if you start looking at this trend. So, at first the kids didn't know what they valued, so they had to work with them. But now on their name badge, it has their value. Johnny Smith, family, whatever it might be. Staff did the same exercise. What do you value? Then it might be Dr. So-and-so, friends, faith, family, whatever it might be. So now everyone has on their name badge their value. It changes that power differential in our own hierarchy in our system, right? Now I meet with you, I'm gonna do an evaluation or whatever and I say, you know what, my value is family too, so is yours, tell me about your family. And it makes us realize we're a lot more alike than we are different. Some of us have had really better roads ahead of us, right? But this changes up the whole dynamic when we start to understand, you know what, we can comfort rather than control. And here's the big one, you don't have to be a therapist to be therapeutic. And the best therapists I know are oftentimes not therapists. So another thing that we are so committed to is elevating, somebody said they were in workforce development, is elevating the levels of the staff that has most contact with individuals served. Because you're looking at your direct care staff, your case managers, your officers in criminal justice, whatever, and they're often the ones that get the least amount of support, get written up the most, right? Get hurt the most, make the least amount of money, right? They need to be elevated, and we've seen some programs that are doing amazing things. At Ancora State Hospital, the direct care staff, these large guys that were oftentimes the ones who were responding to codes when someone had to be secluded or restrained, that all changed up, and now they've called themselves the trauma champions, and they're there to prevent someone from getting to the point that they're going to be so agitated that they're going to go off and they're going to do a restraint seclusion. It's amazing how it elevated them. They're now the trainers. They're training the psychiatrists. They're training everyone. They're traveling and doing talks about what a difference it makes when we respect and elevate them. It's almost as if the more degrees we get behind our names, the less the contact we have with people served. Anybody ever notice that? Right? It almost puts us away. You have people in your programs and your residential and in different programs that are there 24/7. When those of us that are more the professional staff or whatever can leave. We can go out to lunch, we can do whatever. So that's one of the things that has to be flipped around. Your caseworkers and your community programs with kids, right? Their work is really hard. It's really, really hard. How do we elevate them? How do we support them on a daily basis? One of the things that we see that's really important that doesn't happen enough is supervision about your own pain and that relationship that you're having with the person served. We used to call it transference and countertransference in the old days. Now supervision is how to fill out your timesheet, what you better not do, right? But no one takes that time to do that kind of supervision around we're dealing with relationships and how do we support one another through that, okay? So these kinds of shifts have to happen. It isn't enough to go to a training on trauma-informed care, right? That's step one. Then step two, maybe what can we do about it to help people in their healing? And then the next one, okay, let's dig down and even deeper. What kind of programs can we put in our community that elevates the community so we prevent this from happening in the first place, right? Wouldn't that be great? It kind of sounds like utopia, doesn't it? But you know, that's what happens. We've done quite a bit of work in Baltimore City after the unrest that's happened in the city there. And what was so clear to me was everyone was in pain. I mean, it was pain, pain, pain all over the place. The police, the stories that they told of what their life is like. You know, Baltimore is struggling a bit. It's a fabulous city with a huge soul, but it's a city that has you know, quite a bit of pain. And one officer's right after the uprising, he said to me, you know, learning about trauma is so important. We've never heard this before. We've never heard this before. And he said, learning about trauma is gonna make me a better cop, because you know what? I might not fire my gun, but I might go to pull out my gun faster than I should, right? Because he said, I wanna get home that night. I have a gun pulled at me. I'm just reacting, and I'm going to do the same thing. I'm hypervigilant, hyper-aroused, you know, whatever it might be. He said, I'm gonna think differently about this now. But my favorite thing he said to me, he said, it's gonna make me a better husband. And I said, okay, love that. I didn't know I was doing that, but anything I can make people a better husband, I'm all for it. So I said, okay, how's that? He said, my wife is a hoarder. And he said, when I come home, he was a detective. Actually, his job was he was at shock trauma in Baltimore City to support families of officers that were shot, right? That was a full-time job for him. That's crazy, right? That's crazy. So he said, my wife is a hoarder. And he said, I come home and there's more stuff in the house. She's going to yard sales, there's stuff. And he said, it was really causing big problems in my marriage. I come home, I'm stressed, I don't need to see this. He said, but now that I'm understanding this, he said, my wife is a trauma survivor. My wife was homeless. I get it now. No one ever explained to me, or I never understood that was her comfort, right? That there's meaning behind behavior. He said, this is going to change the way I address this with her, and I'm going to understand that she needs comfort. And that's what this stuff is bringing her, right? And that's what we need to look at in all of our programs. When we talk about implementing this kind of approach, it's not just trauma-informed, it's really just treating one another with kindness and dignity and respect, right? We want to call it trauma-informed, but we should be treating everybody, whether they have trauma or not trauma. I mean, everybody should be treated like this. In University of Maryland, Department of Virology, we're doing a project with folks living with HIV. And they told us of a story about, you know, who is being, quote, compliant with medication regime, et cetera, et cetera. They told a story of a woman that came into the clinic, and she's met by the receptionist with, you're late. This is the second time you're late. We can't see you today. Okay? The woman left and never came back. Never came back. Humiliation, shame, she's already humiliated enough. We thought, what could you do differently? Well, now we're training the receptionist, and just to say things differently, like if they had just said, you know what, we're so glad you're here. We know how hard it is to take 2 buses and to get childcare. We're so glad you're here. Changed up the whole thing versus, you're late, we can't see you today, right? Not understanding what it took for that woman to get there. Simple things like that make such a difference in how we bring people into our system. So when we're thinking about trauma, we're thinking about how many symptoms do you see are really adaptations. You're going to hear from Handle with Care on like the importance of that child who's dysregulated at night because something happened to them, whether they witnessed violence in their community or whatever, and goes into school the next day and can't sit still, you know, doesn't have homework done, whatever it might be. That's putting that child right down that road to get that diagnosis, when that symptom is really adaptive. How many of the symptoms that we see are adaptations? The opiate epidemic, you know, how much of that is an adaptation, you know, to what happened? How many depression? Bipolar, you know, I go into programs, juvenile justice programs, for example, you know, all the girls, you know, diagnosed ADHD and then comes bipolar, right? When really someone comes in, psychiatrist comes in a couple times a week, they get all the kids that are having the most problems, they see them for 10, 15 minutes, diagnose, right? So then that child has also a criminal justice history and now a mental health history, which starts shutting doors down to programs. You know, you can't come in here because you're juvenile services, you can't come in here because mental health, shutting down services when really It's an understandable response to an unfortunate situation, right? Some people, might have become dissociative at the time of the trauma, might take themselves out of that, and you really split away that conscious memory of what happened. But trauma lives in your body. Bessel van der Kolk, a leading psychiatrist in the world in trauma, that's what he says, trauma lives in your body. And he wrote a book called The Body Keeps the Score. And he says, you know what, you don't need medication stat, you need a yoga mat stat, right? You need a yoga mat stat, because trauma lives in your body. So you might have all these body memories that are coming up. You might have that hyperarousal, the anxiety, and what better way to numb it out than to use, or to self-injure, or to whatever we might do in order to cope. So many of these symptoms are adaptive, and instead it's very easy for us to diagnose and medicate, right? And how many people do I heard that, well, you know what, there's nothing we can do, she's borderline. Well, no, that means no, she's a trauma survivor, right? But how often does that happen, that we are able to label, and in how many programs do we get down to that healing? Did anyone see Oprah on 60 Minutes when she talked about trauma? Yeah. The best thing she did anybody see her interview with her best friend Gayle King before? Was that the best? That was the most real. So she has this interview with Gayle King, and she's talking about how someone told her about trauma. She didn't know, never had thought about that relationship. And she said, first, she said, we're doing everything wrong. Our housing programs, our work programs, we're doing everything wrong. She went and had everyone at her school in Africa trained in understanding trauma and what the girls are bringing into school. But what she said that I love is, she said, I learned that the first thing we have to do is heal the hole in our soul, right? Is heal that hole in our soul. Because otherwise we're just loading on stuff. We're just loading on stuff without getting deep down to that healing. Because unless you can heal, you can't learn. You can't recover, right? I mean, healing gives us a whole different focus on how we provide services, right? A whole different focus, and it's an uplifting focus versus a focus that you're constantly looking at a we-they thing. When we look at so many of the folks in our public health systems that are people that are in pain, then we become part of that healing relationship, which makes us all feel better too, because we feel like we're really making a difference. So symptoms is adaptation, and then finally, the healing happens in relationship. That's really what it's all about. It doesn't really happen on a webinar, surprise, but I don't know if a lot of healing goes on in webinars. We all are webinared out, and that's important for information, absolutely. But the healing happens in our relationships, and I know you guys do that every day. So I'm going to now show. Has anybody seen Brene Brown? Everybody knows Brene Brown, right? Brene Brown is a social worker. She does a lot of work in shame, humiliation. This is a really sweet little 3-minute clip on the difference between sympathy and empathy. And so you can get this on YouTube. It's Brene, B-R-E-N-E, Brown.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, "I don't even know what to say right now. I'm just so glad you told me." Because the truth is, rarely can a response make something better. What makes something better is connection.
So SAMHSA brought together several years ago a whole host of folks, trauma survivors, peers, academics, clinicians, to come up with a definition of trauma that wouldn't end up in the DSM, that would be as relevant to our work in criminal justice as it is in homeless services, as it is in substance use. And this is the definition that we came up with. SAMHSA also put it out on the internet, literally had 20,000 responses to it, so we tweaked it according to the responses that we got. But this is what we came up with, that individual trauma results from an event, so something happened, or series of events or set of circumstances that's experienced by the individual as physically or emotionally harmful or life-threatening, and that has long-lasting effects on the individual's functioning, whether that's mental, physical, social, emotional, or spiritual well-being. Make sense? It's not going to end up in the DSM. We're not going to just medicate it, right? So an easy way to think about that, we have to have this kind of stuff, the 3 E's, right? So the event, something happened. You had a car accident. You had a death. You witnessed violence. Remember, that experience of witnessing the violence can be as traumatic as the violence itself. I just read an article about PTSD levels in correctional officers, and it was equal to people coming back from combat. So huge, we're working in highly traumatized environments. So something happened. But what makes it traumatic is that experience of it. What's traumatic for me might not be traumatic for you. I might be a child who sleeps through domestic violence in the home. You might be a child who stays awake petrified and develops different kinds of symptoms. I might be someone who, uncle comes to abuse at night. You might be someone who uncle doesn't come to abuse at night, but you're in the same family. So it's that individual experience that makes it traumatic, and then the long-lasting effects. Okay, so we were in New York, on one of the top floors of a building at NYU, and big mental health, trauma, criminal justice conference, and the fire alarm goes off. So we did what everybody does, we sat there and said, this will end. So they came up into the room and they said, you all have to vacate the building. You have to leave. So 150 people, when you can't take the elevator during a fire alarm, so 150 people were going down the steps, 9th floor, and you know how things echo in stairwells. We're going down the steps. Well, above us was the dietary department, and it was getting close to lunch, and they were very diligent in wanting to bring our box lunches down. So they had one of those double-tiered metal carts. They're carrying it down the steps, and they dropped it. So they're like 3 stories above us, right? And where were we? What city? New York. We were at NYU. We're in New York, okay? So we're up there. Here comes this cart. You could see, no one fought, but you could see some flight and freeze going on. Some people started running, some people got... Okay, so we get outside, and the security came up and said, look, that was a false alarm, everything's good, the noise that you heard was the cart. And so a lot of us are, that was petrifying. But there were people that were in Manhattan on 9/11 that experienced it firsthand that could not even go back in the building. That was even after they were told it was a cart falling down the steps, everybody's safe, you can go back in. It's that individual experience was so different for them, it was petrifying for all of us. But those of us that were not in the city, we had a different frame of reference, didn't we? So that makes a huge difference. So it's that event, but it's not the event, it's the experience of that event is what makes something traumatic. I was in we've been doing some work in Washington, D.C. at Children's Hospital. And there was, we were brought in because they were having some issues with seclusions and restraints in the hospital. So we worked with the staff and we talked about trauma, and the staff said, you know, we kind of understand why maybe bedtime is an issue and why these kids might, quote, act out at bedtime, understand that. But they said the second highest incident with seclusion and restraint is shower time. And I said, okay, why do you think that? They're like, well, you know, they have to take their clothes off, obviously. Maybe we can change that up and say, do you want us to stay outside of the door or inside of the door, whatever it might be. But the other reason was a lot of the kids that were coming in from foster care or whatever did not have clean clothes to put on after they showered. I mean, who knew? Did not have clean clothes to put on after they showered. So rather than feel that humiliation and shame, they fought. It's easier to push people away than feel vulnerable, right? It was about pajamas. Who would have known? I mean, they should know. I mean, you're clinicians. I mean, you should be kind of trying to get down to that. But instead, those children were being restrained, right? It's just making things worse. Now that they understood, I'm like, just go buy pajamas and have them here. I'm sure you have money. You can just get pajamas, have clean pajamas for these kids, so you can prevent. You're going to comfort rather than control, and you're going to understand there's meaning in that behavior. And think about how much kids fighting, how much is that self-protective, right? How much is that I'm going to push you away to keep you from being vulnerable? The other thing, we were in New York, in Williamsburg, serving, working with a program that served Holocaust survivors. 90 Holocaust survivors are being served by this program in Williamsburg. And so one of the social workers told me she went to a woman's house, her little apartment, to do some support for her, and she wore black boots. Now, who in Manhattan does not wear black boots? Everyone wears black boots, right? And she said to the social worker, the elderly woman, you may never wear black boots in here again. She's like, okay. Anybody know why? Yes, and she was 3 years old when she went into a camp, and her eyes saw those boots, right? This is what's so important for us to understand, because unless we get to understand where that behavior comes from, we don't understand, and there's meaning behind behavior, and then we can do something about it. But how often do we really look beyond your diagnosis, your behavior, and how many of our programs are just about trying to control that, right? And just remember that in that comfort, you're going to get that control. So does this make sense, this definition to everybody? And this should cross over everything. I mean, this should cross over all systems. So it's that event, that experience, but again, it's that long-lasting effects that make something traumatic. And traumatic events, I think we all know, abuse. But witnessing of violence, right, is as traumatic as experiencing that violence yourself. Abandonment is hugely traumatic. We did a program for pregnant incarcerated women years ago called Tamar's Children. And we brought women out of criminal justice, and I don't know what I was thinking, because we all lived in we had this convent. I mean, the women lived we had a vacant convent that we got to use. So we had postpartum, pregnant, women coming out of detention, everybody living in the same facility. Talk about rock and roll, right? You got emotion, you got the hormones flowing, right? So it really ended up being like an incredible community that the women supported one another. So they were getting great services. We had another grant from SAMHSA to do this. They were getting incredible robust trauma treatment, trauma-specific intensive clinical work. They were getting great substance use services. We had a HUD grant attached to them so they could move out into the community with their baby and have a HUD shelter plus care certificate. They were working with doulas and midwives, and the chief OBGYN at university was delivering the babies. We had everything going on. But when it came time to nursing, no one would nurse, no matter what we did. We brought in the Leche League, the African American Breastfeeding Alliance, prevention. We tried to do whatever we could until we processed it clinically with the women, and they were able to get clear as they were healing. Most of these women had lost kids to the system before, right? They were pregnant, incarcerated, we got them out, they lived in this secure facility. But as they were healing, they could not desexualize the act of nursing. Either it was triggering to them because of what happened to them, or, this was even more significant to me, they thought they were abusing their own child. They thought they were forcing their own child into a sexual act as they had been forced to do, right? Heavy stuff. So you think about the issues with nursing, and you think about how we try to, in communities where it isn't so much support, are they really getting at the trauma? I mean, is there really something behind that why they wouldn't? So once we worked on it, and once we processed it, and once we started that healing, then we were able to move forward, but not until. So all of these traumatic events, you're looking at the abuse, you're looking at loss, but the chronic stressors, I think, are what are really affecting our communities. We're looking at everything from poverty to racism to historical trauma, right? Trauma gets passed down by the generations. You know, those black boots. Another woman in that program serving the Holocaust victims, one woman said, I can't have yellow curtains. One of the case managers was putting yellow curtains up in her kitchen. And she said, no yellow. Well, why is that? The stars on the uniform were yellow, right? No yellow, no yellow. Incredible stuff. So these also chronic community stressors, right? What is it like for kids to walk down the streets and this is what they see? Oftentimes in Baltimore City, this is of course important to honor the person that was killed on that corner, but this is on the parking lot of a program for women and children, women that are coming out of corrections, women that are coming out of homelessness, women that are trauma survivors, and they said they can't feel safe because they look out their window and this is what they see. It's a reminder that someone was killed right outside of my window. And if you can't feel safe, you can't heal. If you can't feel safe, you cannot heal. So reminders, and how many the kids that come walk through communities in every other block, they're seeing this kind of reminder. Okay? So, other creative things that folks do in terms of in community health programs. Bon Secours Hospital is a hospital in Baltimore City that serves a very challenged community. They have inpatient psych, inpatient substance use, they have community programs, they have social services, the whole bit. So we were doing some work with them, and under the leadership of this incredible 73-year-old sister of Bon Secours, who's amazing, she had us come in and she wanted to train everybody on understanding trauma. So we're doing the training, and she had all the housekeepers there. And I said, I love this, I love this. We had very few physicians, we had all the housekeepers, and we had all of the officers that did the front desk and all. And so I talked to him, I said, no, tell me, explain this. Why is this is so important to have housekeepers there? And so the housekeeper said to me, when they do rounds and people in white coats surround the base of someone's bed, right? No one will talk. Remember, they're serving a hugely impoverished community. You've got this power control thing. You've got people in white coats. You have the person in the bed, right? No one talks. The housekeeper said, when we come in behind them, everybody talks to us. We hear everything, right? So they made them trauma-responsive housekeepers. What do you think that did to elevate them? Speaking of workforce development, right? Whoever was saying that, they're not seen as invisible, right? They're not seen as just the person that empties the trash. They're seen as part of this therapeutic milieu. And they have that on their badge. They're the trauma-responsive housekeepers, right? Because they are the therapist. And now you have some of the physicians going to ask them questions about the patient. So what do you think? love it. You know, these kinds of things, you do not have to be a therapist to be therapeutic. In another hospital we were working at in Florida, Larkin Hospital, Miami, again serves a community that has many struggles. They wanted us to help them in their ER, and their ER was like a room about this size, but there were no separate rooms, there were just curtains, So you can imagine it was kind of rock and roll. You could hear everything. People were coming in for psych evals, for detox, for somatic issues. Kids were coming in. You could hear everything. So like, what can we do to keep this place calm? We are constantly having to restrain people in here. So the first thing we said was, we look around the ER, and every sign that was up talked about a disease that if you didn't come in thinking you had, you'd think you'd have it by the time you were laying there, right? You'd see symptom of a heart attack, symptom of a stroke, STDs. Every place you looked, I mean, if it were me, I would get everything. I'd be laying there going, oh my God, you know, I think I'm having a stroke now on top of everything, right? Because I have that symptom. So we said, first take these down. Take all these down. They painted the walls nice color. They put those films on the fluorescent lights, you know, so you could look up and see clouds. They have a cart that goes around that has sensory things for people to calm down, right? Because sometimes verbal doesn't work for lots of reasons. Sometimes people that have trauma, part of your brain, the Broca's area that's responsible for speech, shuts down. I mean, there's all these different reasons that speech, that we don't have the words, and speech isn't the easiest, and sometimes people can't talk about it. But you give somebody a weighted blanket, right? When they're starting to feel they're losing control, that makes you feel in control. Weighted blankets are fabulous. Every program that has kids should have one in their waiting room or wherever foster care. I mean, weighted blankets really, really help. Sensory things help. So they have a whole cart that people can use while they're waiting. Headsets. If your sensory issues are around noise, I mean, mine are. I couldn't stand that. I mean, I'd have to block out the noise, right? Noise is just a big thing for me. It's distracting. But so they got headsets that people could put on and block out that noise. This is prevention. This is keeping people from being so agitated because of the situation, right? That they can keep it down. They got those adult coloring books, the mandalas that you can do. That is a very soothing thing. It's that repetitive stuff is very, very soothing. Here's the big one. They had snacks. How many programs, you can't have snacks, it's going to bring in rodents, or, you know, I mean, I've heard every excuse in the book why you can't have snacks. Snacks could go a long way in making people feel comforted, right? This is not rocket science, is it? This is simple stuff that keeps things calm, and guess what? It's better for staff, because staff then don't have to deal with all of these people that are totally triggering each other and highly traumatized, right? So that's what they're doing. So some of these simple things, I'm telling you, pajamas for kids, you know, sensory cards, this is not that complicated. Because again, we comfort rather than control. This is our nation's capital, okay? This is DC General Hospital. One day I'm gonna get in big trouble for this, but so far I've been okay. Or maybe one day they'll take it down. Maybe one day they'll take it down because they'll be appalled that I show it all over the country. But this is not trauma informed, by the way, just saying. This is DC Department of Health. This is where the homeless children's services are, women and children. This is where emergency psychiatric services are. This is where medical services are. This is where the jail is, and this is the entrance, right? Now, we all know about HIPAA, right? This to me is like HIPAA times 200, right? You're walking down the street, what would you do? Which way would you go? I think I'd turn this way if somebody was behind me. But the point of it is, this is how we oftentimes treat our most marginalized community members. Go into your programs, go into social services, go in there and check out what signs are on the wall. You in Johnson City, you probably have it all under control and it's probably all good. But lots of places that I go, I look at these signs and they're horrific. You know, they're just horribly demoralizing to people in need. It further shames, right? And we do that without realizing it. When you go into private facilities, you don't see all these rules on the walls, right? You don't see all of the, don't use that bathroom, staff only, or all of these kinds of things, all these things, what you can't do, what you better not do, it's infantilizing, it's traumatizing, it's humiliating. I was in one health center a couple weeks ago, and I said, you've got to get rid of these signs. Number one, most of the people, a lot of the people come from the Hispanic community, and everything's in English, so that was kind of a little red flag there. And then on the television, they had the television showing in the waiting room, but it was again showing diseases, right? It was showing diseases and all of this kind of stuff. I said, can't you show those kittens frolicking, you know, those little those puppies playing or something, because you're totally making people hyper anxious in that waiting room for no reason when you don't have to. So think about how you enter into your programs, think about what your welcoming is, think about what the kind of signage you have on the walls. That's a good first start to thinking through things through differently. This is St. Agnes Hospital in Baltimore, serves the same population as what you just saw in DC. But talk about a different vibe. It's patients are our passion, physicians and associates are pride, and healing is our joy. Health Enterprise Zone, same population, different vibe. This is what you see when you walk in there. May his dear sheltering wing be over you through all the storms. Isn't that a little bit different than STDs, chest clinic, right? Where would you feel better, right? But the point of it is, so much of this stuff is so simple because we want to lift people up rather than just taking them down. There's a wonderful article by, I'm gonna have to spell his name correctly. It's Joan Gillece, G-I-N-W-R-I-G-H-T. He is he's the head of African American Studies and in the Education Department of San Francisco State, and he's incredible. He says we need to switch to the future of healing. It is really about shifting from healing, from trauma-informed care to healing-centered engagement. Because he said he was working with a group of young boys and they talking to them about trauma. He's trying to explain trauma to them, and they said, stop. We're more than our trauma. We're more than our trauma. We need to really talk about what we did, to what we're doing now and what our strengths are. We're more than our trauma. So healing-centered engagement. Again, it encompasses everything we're trying to do, but you're doing it in a way that is strength-based versus deficit-based. Make sense? Okay. So, this is another one at St. Agnes Hospital. Reverence and respect for diversity. And I share these with you because it's such a different way of the way we view those that we serve versus what you saw at DC Health. I think you guys are going to hear about the ACE study later, so I'm just going to pass through this. And I think what important, you all know about the ACE, obviously, you've been hanging out with Becky and Andrea, you know this. But I think what's really important about the ACE study to realize is when Dr. Felitti did the ACE study, it was really intended because he had this hunch is there's something behind why some people were successful with weight loss and some people weren't. And he's a prevention guy. And what he found, then again, was really looking at all of the different health issues that come at their basis of early childhood trauma. So it isn't supposed to be a diagnostic tool per se, and we don't want to just look at the number of ACE scores that people have and put them in a doomed kind of pocket. You don't want to say, I have a 6, I'm going to be a substance user. Well, some of us have high ACE scores and are not. It paints us a really good picture of the relationship between adverse childhood events and somatic as well as psychological issues, but it's just a start, right? It's really just a start. It helps us understand so we can move forward to move on that healing. So you're going to hear, I'm sure, about the ACEs in a little bit later on today. Just prevalence, I think you guys probably know this, the prevalence of trauma in the lives of those folks that we serve. Again, up to, you look at the 75% of women in treatment, in substance use treatment report histories of trauma, a lot of incest, okay? So if we know this, and if these data really show the prevalence, shouldn't it be the primary issue that we treat? And you go in, I read charts in hospitals and state hospitals, and when I say to the staff, how many people do you think here have trauma histories? Well, they all do. Okay, well, why isn't it in the treatment plan, right? It becomes, it's in the psychosocial, these horrific stories of what happened, but it's not getting translated into the treatment plan. What if our treatment planning, for those of you that are clinical, and what if our treatment planning was about finding out what is your strength, and that's what we work towards, right? Versus looking at our deficits, what are your goals? Anybody, we were doing a focus group with girls in the juvenile justice system and asked them, you know, tell us what you do that you're proud of. Not one girl could tell us one thing. But if we said, please tell us your goals, they'd say everything they think that we want to hear. Take my medicine, right? Stay out of trouble. Go to school, right? Well, guess what? That's not going to happen unless, as Oprah says, we heal that hole in the soul. Unless we start building that child up. So if we know we have this highly traumatized population and people are coming into all of our systems, and it's why you're doing the good work in Johnson City, how can we then take the next step and change our practices, right? How can we change what happens in our programs? And still having to do the things that we do. Like, for example, one program we were working in, substance use program, I was on my way there, and traffic is horrific in DC, right? So I'm on my way driving there on a Monday morning, and of course I'm stuck in traffic, so I'm gonna call there and just see what happens on a Monday morning if you call to see if you need services. Well, guess what I heard? Press 1 if you have a problem with opiates. Press 2, alcohol. Press 3, well, that makes you want to hang up anyway. So then no one even answered. So I get in there and I'm asking them about what they do. And they say, well, intake, which was 40 pages, intake. And then we ask them, you know, what drugs we're on. Okay, that's a whole nother process. And then we have them go do a urinalysis. I said, okay, could you maybe just hold up on that just a little bit? Right, you have people that are coming in for services. You've already asked them, what drugs are you on? Could you maybe just trust them for a minute? They said, no, they lie. We like to say people that treat those we serve like that should take their gifts and graces to other places. That's our motto. Because if that's how you're viewing a person served, they lie, you're in the wrong business. You're in the wrong business. I said, you can explain why you have to do this for insurance, for whatever it is, but you've just asked them 800 things. Why do you think people aren't going to tell you the truth when they're there for substance use, right? That makes no sense, but it was just that, you know, just that mindset. So if we know that the prevalence and the trauma behind it, shouldn't the first thing we do be treating that trauma history? Again, just data. But these I share with you because this is when people get it. And this is a children's, a girls' detention facility in Marion, Florida. The warden totally got trauma. She came to a training with one of her officers. She understood. The girls, you know, that put them in their cells at night, and the girls would be banging on their door, right? Now, they thought oppositional, defiant, attention-seeking, manipulative. Well, once they understood trauma and were able to learn about what's behind it, they said, we get it now. We get it. Things happened at night. They're scared. If you're a victim of abandonment and you're put in that cell and the door's locked, it's only going to bring back all of those abandonment issues. So one of the officers said, you know what? I get it. I'm an artist. Could I try to paint every cell? So she said, of course, yes. So can everybody see this? There's lights we could hit somewhere. I don't know, is that, you can't, can everybody, it's probably hard to see, isn't it? But you get the idea. They got rid of these terrible, uncomfortable blankets, and a fleece blanket went a long way because you're comforting rather than controlling. You're not coddling behavior, you're not reinforcing negative behavior, you're preventing it. Every single cell this officer painted. There's another one, right? This amazing warden, one of my favorite things that she did, she said, you know, this is working really well. Bedtime is calm, the girls are chilling out, and she said, you know, I'm gonna try something else. She said, normally the girls are sleeping in gym shorts and t-shirts, and you strut around tough, right? She said, I'm going to get them long flannel nightgowns. And I said, I love that, tell me your reasoning behind it. She said, it'll change the way the girls feel about themselves. You're gonna feel not like a bad girl, that people are gonna understand there are girls that bad things happen to. You're gonna feel, it's very different. She said the officers are gonna see them differently. rather than strutting around in your gym shorts if you're scooting around in your little long flannel nightgown. But the most brilliant thing she said was, and have you ever tried to fight in a long flannel nightgown? She said, you cannot fight in a long flannel nightgown. They're gonna get all caught up in it beforehand. Prevention, 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 comfort rather than control. And she reduced the anxiety on the staff because bedtime wasn't horrible. I had another officer in another facility who, when she finally had the opportunity to understand what's behind behavior versus just being the rule enforcer, which nobody ever bothers to teach those staff basic understanding of the meaning behind behavior. They learn what to do, what to say, what not. We don't talk about what to do and what not to say. We want to bring it out in folks when they understand the meaning behind behavior. They come up with their good creative ideas. I could have never come up with long flannel nightgown evidence-based therapy, right? You know, this was not in psychiatric services, but it was brilliant. I mean, just brilliant. Another officer said to me, you know, she had girls that they would, some of the girls would not be able to stay in school, right? So they'd get sent back up to the tier. They couldn't sit still in school. And of course, further shame, they come back to the tier and then hear, what's the matter with you? You know, you can't even sit still in school. Shame, shame, shame. That's gonna pop up some more behavior because you're feeling vulnerable and shame. So when she understood trauma, she said, you know what? I'm gonna read to them at night. And I was like, hallelujah. She said, I'm gonna read them storybooks at night. It worked for my kids. Why would I think it wouldn't work for these kids? So she started reading to them at night. She started reading to them, and everybody calmed down. Before, the way they're putting them to sleep is meds, right? I mean, that's what's happened. Girls dysregulated, PRN, here we go, right? Reads to them. That was working so well. A lot of the girls that couldn't sit still in school, she realized they're not comprehending US history. Cognitively, they're having issues. US history is priority 0 in their life, but when she started reading them their history book, what do you think happened? Yeah, they could stay in school. The girls were able to participate. They felt great about themselves. The officer felt great. Everybody felt great. It was as simple as her understanding there's meaning behind that behavior and not further demoralizing and shaming that child. Totally uplifting stuff, and it all happens when people get it, and we never tell people what to do. Never, never. We help them become empowered through what we're doing in programs to be able to use their own good judgment and elevating those that have the most contact with folks served, because they're oftentimes afraid to do things. I hear from everybody, well, we would totally do this, but we'll get written up. You know, or we would totally do this, but we're not allowed to do that, or we would, whatever it might be. So empowering those staff has made such a difference. And here's, look at this one. Everybody see that? Now, I have showed this one place, and somebody said to me, well, they're never going to want to leave. I said, yes, they will. I mean, this is still a cell, guys. This is still a cell, right? A locked cell with a toilet sink combo in it. So, you know, and so there's meaning behind all of this behavior. And some of it is so simple. There's, in one forensic program for youth that we were working with, there was a child who had just gotten out of seclusion for throwing a chair. He was in this program for kids that are involved in criminal justice and had psychiatric diagnosis. He was in a maximum security facility. And so the staff said, well, I said, well, can you bring him out and we can talk? Because the staff said, unprovoked, for no reason at all, he just got up and threw the chair. Well, there's a reason. We might not know the reason. There's a stimulus, there's a response, right? We might not know the reason. So they brought him out and they said, he's never gonna talk to you. He's cognitively impaired and he's psychotic. Comes out, they sit him, you know, and they sit him, all the staff is sitting around a circle. And they bring him out for me to talk to him. And you can see them saying, well, we'll show her. I mean, she's not gonna get this out and he's never gonna talk to her. There we go. Well, I bring him out and I said to him, what happened before you threw that chair? And he said, as clear as can be, someone said something about my mommy. Well, it was visiting day. He was a foster care kid, mother never shows up. I didn't want to tell them I think it's a strength that he threw the chair at the wall and not someone, because they were not buying that at all, because it's state property. You know, you may not damage state property, but he throws it against the wall. So somebody says something is mommy. The staff thinks there's no reason, right? What did they do? They put him in seclusion. What did that do? I mean, if his trigger was mommy didn't show up, you're just reenacting and exacerbating that whole thing. So I said, before you threw that chair, does your body tell you anything? He said, I shake my leg really, really fast. So there we had the stimulus, that abandonment, visiting day, mother never comes, shame, humility. We know early warning sign, I shake my leg really, really fast. And then I said, what could we do that would help you when you need to connect with your mother and she's not coming? And he said, if I could just draw her a picture. Well, staff said he can't have a pencil or a pen. It's a weapon, right? He can't have paper, he will stuff up his toilet, right? But when they got it and understood, they got him one of the marble notebooks without the spirals and a big chunky magic marker, and guess what? He carried it around with him. He told us. So that's his plan. We know what sets him off. We know what that early warning. You can do this with kids in school. You can do this with kids in foster care. You can do this with anyone. You know, get the kids mindfulness. Mindfulness is so awesome because it just helps people self-regulate and helps people calm themselves down. I'm working with programs in some Baltimore City schools where instead of a detention, you're having mindfulness and yoga, right? That's very different. You're teaching the kids rather than detention. Mindfulness and yoga, you're teaching them strategies. One school I was working with, they loved that they had kids that couldn't sit still, so they built a few desks on stationary bikes, right? They went out and got stationary bikes like at Goodwill or whatever, and they had the janitors be able to build the desk right on top of it. So now if a child can't sit still, rather than spiraling out, they can go get on that bike, right? And you can pedal, 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 pedal. You can just get on the bike if you feel like it, but it doesn't further shame that child. So, this is why we do this work, because this is kind of the road we're going down, right? So we do this work in order to prevent. Not that medication is bad, medication is not bad at all, but medication just is part of the solution. It's not the solution. It's part of it, and it's not the only solution. So this is why we do this, and so I'm going to close with kind of our motto in our office is from Maya Angelou, who says, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And how true is that? And I think with all of us in this work, we have that opportunity to do this every day. And the more you get into the trauma, the more you see things so differently. Okay, well, I think it's break time, unless Becky, you want to say something.